today we will discuss about the skeletal muscle relaxants. So what we are studying today? This is again a very interesting and somewhat difficult one. Skeletal muscle relaxant means we are relaxing the skeletal muscle. When it will be required? Mainly it will be required when we need some surgery. Okay. In some surgery we need relaxation of the muscles. In those cases with general anesthetics, the skeletal muscle relaxants can be used. In another cases, if there is some spasmodic conditions, for example cerebral palsy, spasmodic torticollis, etc. In those cases also some skeletal muscle relaxants can be used. These skeletal muscle relaxants broadly can be divided into different areas, but mostly we will deal with the neuromuscular blocking agents. And what are these neuromuscular blocking agents? Means these agents does block or intervene in the NM receptor. So already we have read in the NN and NM receptor, this NM receptor is present in the neuromuscular junction. So here these agents mainly act, and just remember mainly two neuromuscular blocking agencies, one is non-depolarizing or competitive, another is depolarizing or non-competitive, just opposite. Competitive, those competitive neuromuscular blockers are non-depolarizing. Why it is called? Competitive means they are doing competition with what? Acetylcholine. So already we know in the NM receptor normally the acetylcholine binds, the acetylcholine normal receptor, NM receptor, nicotinic receptor, NM receptor normally acetylcholine binds. Now this competitive antagonist means they have some affinity towards the NM receptor but no intrinsic activity. You have already read about the antagonist, what is agonist, what is antagonist. So antagonist means they have affinity towards the receptor but no intrinsic activity. Okay. So they compete with the acetylcholine and they blocks the NM receptor so that the acetylcholine cannot act. It is in easy terms, so that there will be flaccid paralysis. Since they are blocking this, there will be no depolarization, there will be no muscle action potential. So that's why they are also called non-depolarizing muscle relaxant. So competitive muscle relaxant is also known as non-depolarizing muscle relaxant. Okay. There is another type of muscle relaxant, that is depolarizing muscle relaxant or non-competitive. Just opposite. Here what happens? Here again that molecule also attaches with the NM receptor. So they have affinity, but instead of the competitive blocker where they have no intrinsic activity, here they have some submaximal intrinsic activity. That means they somewhat depolarize that NM receptor, but not to the extent of the acetylcholine. So when they attaches with the NM receptor, this depolarizing muscle relaxants, they submaximally depolarizes the NM receptor and they remain bound with it. They are destroyed very late, so that there will be sustained, the acetylcholine cannot act for a long period of time. So again there will be flaccid paralysis. So here there is no depolarization in the competitive blocker, and in depolarizing blocker there will be sustained depolarization. Again due to the sustained depolarization there will be no muscle action potential propagated. So you need a cycle, there is continuous quanta of acetylcholine is released in the neuromuscular cleft, so that there will be the action potential is generated and ultimately propagated. So when there is no depolarization on the one hand, there will be no muscle action potential. Again when there is sustained depolarization, sustained attachment of some other molecule that causes somewhat intrinsic activity, again there will be no propagated muscle action potential. So this is the main two types of the muscle relaxant. Okay. So let's see. So these mainly act peripherally at neuromuscular junction or muscle fiber itself, what we are discussing. Apart from this, there are some other types where they act on the cerebrospinal axis also to reduce muscle tone or cause paralysis. Okay. Neuromuscular blocking agents, already we have discussed, they are mainly used in concordance with the general anesthetic agents, and centrally acting muscle relaxants are mainly used in different types of the spasmodic conditions. So neuromuscular blockers, they relax normal muscle, mainly in the surgery and assisted ventilation it is used. No central nervous system activity, used primarily as part of general anesthesia. While spasmolytic or central centrally acting skeletal muscle relaxants, they reduce the spasticity, they are centrally acting, there are some exceptions like Dantrolene, we will read about this, and used in a variety of neurologic conditions, neurologic spastic conditions it is mainly used. So, neuromuscular blockers, already I have discussed about the non-depolarizing and depolarizing. So, mainly we are discussing about the neuromuscular blockers or peripherally acting skeletal muscle relaxants. They are broadly divided into non-depolarizing or competitive, already we have discussed, these are the examples, and depolarizing or non-competitive, these are the examples. So, here the prototype is a d-Tubocurarine. Perhaps you have read or you have heard about the Curare. Curare is an arrow poison mainly used by the South American tribes, Curare. If you have read about the Tintins, you have read about the Curare. They are a Curare arrow poison. And they are using this arrow poison, these are mainly obtained from different types of the herbs, and they are filtrated and different molecules are gathered who have this skeletal muscle relaxant activity. That is, when this arrow hits someone or mainly this is used in game hunting, some animals, they causes paralysis of the animals, but usually the death will not happen to the animals. So, it will causes temporary paralysis. Okay. So, from this Curare, d-Tubocurarine is the active substance that can be synthesized. Previously, this d-Tubocurarine, its activity, this was discovered in around 1930s, and then it has been seen that different other newer molecules that have less adverse effects are also can be synthesized. For example, Pancuronium, Vecuronium, Atracurium, Vecuronium, these are other competitive or non-depolarizing skeletal muscle relaxants. And depolarizing or non-competitive, the most common example is the Succinylcholine, apart from there is Decametonium. But remember, only Succinylcholine is normally used clinically. So, within the competitive neuromuscular blocker, this Pancuronium, Vecuronium, Vecuronium, Atracurium, these are used, and within the depolarizing or non-competitive blocker, Succinylcholine is used. And within this Spasmolytics, they may be centrally acting, most commonly centrally acting skeletal muscle relaxants are known as the Spasmolytics. Example is diazepam, we will read later in the CNS chapters about this, clozoxazone, tizanidine, baclofen, etc. And some directly acting, mainly it acts through the calcium receptors, calcium channels, example is the Dantrolene. Okay. So, this is the broad classification of the skeletal muscle relaxants. So, skeletal muscle contraction, how it happens, already we know the NM receptor acetylcholine is released from the preganglionic prejunctional nerve fibers. This acetylcholine attaches with the NM receptors, and then there will be muscle action potential is generated and it will be propagated. So, mechanism of action, competitive antagonist, that also known as the non-depolarizing blockers, already I have discussed, and they can be classified according to their half-lives, like they may be long acting, intermediate acting or short acting. Long acting example is d-Tubocurarine and Pancuronium. Intermediate example is Atracurium, Vecuronium and Vecuronium, and short acting example is the Vecuronium. Okay. So, this classification is according to their actions, time, duration of actions. So, non-depolarizing blockers already I have discussed in a little. So, basically this NM receptor, you can see NM receptor, yes, this NM receptor basically have 5 subunits. Okay. So, alpha, there are 2 alpha subunits there is beta subunit, there is gamma or epsilon subunit and delta subunit. Within these 5 subunits, there are 2 alpha subunits. These 2 alpha subunits basically attaches these acetylcholine molecules. So, this mainly arranges like a rosette-like structure, rosette, and within the center there is sodium channel. Okay. So, these 2 alpha subunits carry 2 acetylcholine binding sites. They have negatively charged group which combine with the cationic head of the acetylcholine, and thus opening of the sodium channel happens. So, NM receptor, this is present in the neuromuscular junction. This NM receptor is a rosette-like structure where there are different subunits of the rosette are there. There are 2 alpha subunits, and these 2 alpha subunits have negatively charged molecule. When acetylcholine is released, when the nerve action potential comes, released in the neuromuscular cleft, and then it attaches with the NM receptor. How it attaches? It attaches with their cationic heads to the negative molecules that is present in the NM receptor rosette-like structure, 2 alpha subunits. And when this attachment happens, there will be opening of the sodium channels. This sodium channel is present at the center of this rosette molecule. Okay. So by this, when the sodium channel opens, then the muscle action potential ultimately propagated. Now most of these competitive blocker or non-depolarizing blocker, they have 2 or more quaternary ammonium compounds. They have quaternary ammonium compounds that looks like that of the acetylcholine. So when this drugs is given, they comes within this neuromuscular cleft and attaches with the NM receptor with the same this positively charged group, with the negatively charged group that is present on the NM receptor. So when they are attaching, by competing with the acetylcholine, acetylcholine cannot bind with this NM receptor. So here they are, the bulk of the antagonist molecule does not allow conformational changes in the subunits, and thus the sodium channel opening does not happen. So when the acetylcholine attaches that 2 alpha subunits, there will be some changes in the structure of the rosette, so that there will be opening of the sodium channel. But when this neuromuscular blocker, competitive neuromuscular blocker comes and attaches with the NM receptor with the same 2 alpha subunits, they ultimately will not allow the conformational changes of the rosette-like structure. So sodium channel opening will not happen. Okay. And these molecules are very bulky in nature, and they are also known as the Pachycurare. We will come to this later. They are also called as the Pachycurare by Bovet, who is a scientist. So the acetylcholine released from the motor nerve endings is not able to combine with its receptor to generate end plate potential. The same thing that reduces the frequency of the channel opening, but not its duration or conductance of a channel once it has opened. When the magnitude of this end plate potential falls below a critical level, it is unable to trigger the muscle action potential, and thus the muscle fails to contract in response to nerve impulse. So nerve impulse is coming, but the muscle fails to contract. This antagonism is surmountable because it is competitive. So if we are using some drugs that will increase the bulk of the acetylcholine, so this antagonism can be surmounted. So that can be done by increasing the concentration of the acetylcholine in vitro and by anticholinesterase in vivo. That is, anticholinesterase drugs already I have discussed, that is neostigmine. When we are giving this neostigmine, so that there will be more availability of the acetylcholine. So when the availability of the acetylcholine is more, so they can compete with again these drugs, these neuromuscular competitive drugs, and they can attach, and then the normal muscle action potential can come. So the antagonism of their actions of this neuromuscular blocker can be done by the anticholinesterases like the neostigmine. So the same thing already we have seen, this is the motor end plate. So when this d-Tubocurarine is the prototype drug like Pancuronium, Vecuronium, etc., when they attaches, the acetylcholine cannot attaches here, and ultimately it will be repulsed back. Okay. So anticholinesterase like neostigmine or hydrophenium preserve the acetylcholine, so there will be more acetylcholine. So ultimately they can reverse the effects of this competitive neuromuscular blockers. So it is clear. So competitive neuromuscular blocker, their action can be reversed by anticholinesterase agent. Example, neostigmine. It is clear. So these drugs mainly have affinity, but they have no intrinsic activity, and they are also known as the Pachycurare. Pachycurare is a bulky molecule, they attaches and there will be no conformational change, no sodium channel opening. So at very high concentration, so when it is given in very high concentration of the drug, these drugs also directly attaches with the sodium channels, and they can also block the sodium channel directly, and that can only partly reverse by the neostigmine. So when there is high amount of the drug is given, we cannot reverse by just giving the neostigmine. That is the problem. The competitive blockers also block the prejunctional nicotinic receptor. So there are some nicotinic receptor present in the prejunctional. When the acetylcholine comes in the neuromuscular cleft, some acts on the postjunctional neurons mainly to propagate the action potential. Some acetylcholine also acts back in the prejunctional acetylcholine receptors, so that there will be more quanta of the acetylcholine is released. Okay. So that will be a cycle. So, since activation of these receptors by acetylcholine normally facilitates mobilization of additional quanta of acetylcholine from the axons to the motor nerve endings, when this blockade happens, they contributes to depression of the neuromuscular transmission. So, ultimately, if we are continuing giving this drug, there will be gradual decrease of their contraction. So, this is known as the fade phenomenon, fading. So, we are giving some impulse. So, there is some muscle fiber, there is nerve ending, we are giving some electrical stimulus or we are stimulating the nerve, but the contraction of the muscle gradually fades, gradually diminishes. This happens in case of the competitive neuromuscular blockers, and this is known as the fade phenomenon. That is, twitch responses during partial block are progressively depressed on repetitive stimulation. Okay. So, we will discuss about this again later. Okay. Just remember, this is known as the fade phenomenon. So, what are the actions? When this happens, there will be muscle weakness and flaccid paralysis happens, flaccid paralysis. And there are some order of the muscles and how the drug is distributed and how the different muscles are sensitized to the drug ultimately determine which muscles will be affected first, and again during the recovery phase which muscles will be affected last. For example, extrinsic eye muscles, muscles of the finger, this will be paralyzed first, and again this will be the return, again it will be happen first. Then neck muscles, face, hands, feet, trunk, and ultimately if very high amount of the drug is given, there may be some respiratory muscle paralysis and death can also happen. Okay. So, first the extrinsic eye muscles, muscles of the finger and extrinsic eye muscles are first affected. So, when during operation we are giving this drug, we can inspect the extrinsic eye muscles, we can inspect the finger muscles to see whether the drug action is happening or not. Again, after operation, when the patient is recovering, we have to see whether the actions of these drugs is ultimately repulsed back or not. If in some patients the actions of the drug is continuing prolonged, the patient relaxant, the muscle relaxant action is continuing, then we have to give some antagonistic drug. For example, we have to give them neostigmine. Okay, that is why this is needed. Which muscles is affected first and which is last. So, recovery in the reverse order. So, when the recovery happens in the reverse order. So, consciousness, appreciation of pain, usually it is not affected. So, basically they mainly causes pure muscle relaxation. Autonomic ganglion blocking property is also there, and for some older drugs like d-Tubocurarine, there may be some histamine release. So, there may be chances of the anaphylaxis also is there. In the cardiovascular system, there will be vasodilatation and there will be reduction of the blood pressure usually happens. On the flip side, there will be increase in the heart rate happens. Mainly this happens due to the vagal ganglionic blockade. So, vagal nerve usually supplies, and since they have some ganglionic blocking properties, and in different organs some ganglions are predominant. For example, in the eyes, for example in the cornea and ciliary muscle, some ganglia, parasympathetic ganglia are more prevalent. So, when we are blocking some ganglia in those organs, sympathetic or parasympathetic which is prevalent, their actions will be diminished like this. So, newer competitive blockers like Pancuronium, Vecuronium, etc., they have negligible effect on the blood pressure and heart rate. They have less histamine releasing property also. So, the adverse effects of these drugs are there may be some hypotension, there may be tachycardia, respiratory paralysis may happen if it is given in very high doses, bronchospasm may happen due to the histamine releasing property, aspiration of the gastric contents happens because there will be relaxation of the muscles. So, ultimately if the patient eats something, that food can go into the lungs instead of going into the esophagus because there is relaxation. Okay. So, advantages of the synthetic or newer competitive blockers, what are these? Less histamine release. So, newer agents have less histamine release, less allergy, less anaphylaxis. Do not block the autonomic ganglia. Since the autonomic ganglia are not blocked, there will be less action on different other organs. Spontaneous recovery with most of the drugs, they are short acting, so that there will be after operations usually spontaneous recovery happens. We do not have to give some antagonistic drug. Rapacuronium and Rocuronium have rapid onset of action. So, during operation we can give this within some 2 to 4 minutes, there will be muscle relaxation, we can intervene or we can operate. Atracurium, already we have seen in the metabolism chapter that Atracurium, Atracurium, they are metabolized by a unique mechanism known as the Hofmann elimination. So there will be rearrangement of the molecules, and by this the metabolism happens, so that this metabolism will not be affected by the kidney or liver. So if the patient have some renal disease or if the patient have some hepatic disease, we can give this drug Atracurium, there will not be any problem. Mivacurium is the short acting, very short acting drug. So these are the advantages of the newer competitive or non-depolarizing blockers. Where they are used, already we have discussed, mainly to adjunct to general anesthesia for producing satisfactory skeletal muscle relaxation, for facilitating endotracheal intubation, very common for example, if the patient is going to the ventilator, we have to endotracheal intubate. If the patient is to be given general anesthesia, we have to give the endotracheal intubation. If there is respirator, the patient cannot take the respiration, we have to endotracheal intubation. In those cases, we have to give, usually the raw curonium is preferred due to the rapid onset of action. Apart from this, we can also use Succinylcholine, which is a depolarizing muscle relaxant. Pancuronium individual agent, Pancuronium is a long acting agent, synthetic steroidal compounds, very much potent and longer acting than the prototype drug, which is the d-Tubocurarine. They provides good cardiovascular stability, that is they have less ganglionic blockade activity, seldom induces flushing, anaphylaxis, histamine release, bronchospasm, cardiac arrhythmia, etc. All these incidences are very less. Rapid IV injection may cause rise in blood pressure and tachycardia due to vagal blockade and noradrenaline release. That is why slow IV injection is to be given. It is primarily eliminated by the renal excretion. Because of the longer duration of action, needing reversal, its use is now restricted. Long duration of action, that is why even after operation, the patient, the relaxation, the muscles will be relaxed. That is why there will be paralysis, and there will be also there will be chances of the gastric aspiration, respiratory paralysis also. So when we are using this Pancuronium, after operation, we have to give the neostigmine for reversal. That is why it is lesser used nowadays. Atracurium, Hofmann elimination, already have seen. It is a bis-quaternary competitive blocker, 4 times less potent than the Pancuronium and shorter acting. Usually reversal is not needed, that is why it is also recommended. Hofmann elimination already have discussed. Duration of action is not altered in hepatic or renal insufficiency, already we have discussed. So if you are asked what is the advantage of the Atracurium or its congener Atracurium, so these are the advantages, because they are metabolized by the Hofmann degradation or Hofmann elimination, which is a molecular rearrangement. So they do not need any kidney or liver for their metabolism activity. So if those patients have some hepatic failure or liver failure, that patient needs some operation, we can use this Atracurium as a skeletal muscle relaxant agent. Okay. Raw curonium is another short acting rapid onset action, intermediate duration of action, mainly used in different types of the endotracheal intubation. Usually the reversal not needed, facilitate mechanical ventilation in intensive care units. So more or less this is similar. So this is normal. Acetylcholine acts on the NM receptor. Already we have discussed about the d-Tubocurarine and competitive blocker. Now we will come about the depolarizing blocker. Already we have discussed first about that they causes sustained depolarization. Example is the Succinylcholine, persistent depolarization. So depolarizing blocker, Succinylcholine, mainly they acts brief and quick, and this Succinylcholine, if it is given in also very high dose for a longer period of time, they causes some phase 1 and phase 2. Phase 1 is normal pure depolarizing action, phase 2 is like that of the non-depolarizing and competitive action, that can also happen. There are some genetic variability in metabolism also. So there are some person to person difference how the Succinylcholine acts, and there may be problem of the malignant hyperthermia with this Succinylcholine. So Succinylcholine, again this Succinylcholine also have quaternary ammonium compound, but these molecules are long and slender. That is why again another with that scientist Bovid have called this type of molecules as leptocurare. The competitive neuromuscular blockers are known as the pachycurare, P-A-C-H-Y, pachycurare, because they are bulky molecules, and these are known as the leptocurare because they are long and slender molecules, and they have affinity and they have submaximal intrinsic activity. The competitive ones have no intrinsic activity and they have submaximal intrinsic activity. Okay. So, quaternary ammonium compound succinylcholine is basically, we can say these are two molecules of the acetylcholine joined. Okay. So, they have affinity and submaximal intrinsic activity. They depolarize muscle end plates by opening the sodium channels and initially produce twitching and fasciculations. Since they are causing depolarization, so there will be some contraction, but that contraction is irregular contraction. That is, this is also known as the fasciculation or twitching, rapid some jerking movements that may happen. So, longer lasting depolarization of the muscle end plate happens, that produces repetitive excitation of the fiber, so that there will be refractory to the normal nerve impulse, and they also do not dissociate rapidly from the receptor. Normally acetylcholine attaches, muscle action potential propagated, and then they will be degraded, but here they usually not dissociated, not degraded usually. They induce prolonged partial depolarization of the region around the muscle end plate. So, sodium channels get inactivated because the transmembrane potential drops. So, minimum, you know from the physiology, a minimum transmembrane potential is needed for the propagation of the action potential. Usually that critical muscle action potential drops because there will be repetitive stimulation at very low doses, repetitive stimulation. That is why acetylcholine released from the motor nerve endings is unable to generate propagated muscle action potential, and then again the flaccid paralysis happens. So, it is clear how this how the actions of this depolarizing muscle relaxant. Competitive is easier, already you have seen just competition with the acetylcholine. Here its action is like that of the acetylcholine, but here causes sustained contraction of the muscle action potential. Since there is sustained contraction, there will be fasciculation, ultimately there will be continuous contraction, there will be the critical action potential will be diminished and the muscle action potential cannot be propagated. That is why they are known as the depolarizing agent. So, you may be asked that why these are the depolarizing agent, why they are called? Because normally depolarization is needed for the propagation of the action potential. So, this succinylcholine, in spite of being a depolarizing agent, it is a muscle relaxant. So, that is why this is a depolarizing muscle relaxant or non-competitive muscle relaxant. So, in many species and in also slow contracting soleus muscles or in different muscles, according to their amount that is injected, they causing the phase 1 and phase 2 reactions, already we have discussed. Phase 1 block is the normal depolarizing action, normal, what we have discussed. So, rapid in onset, results from persistent depolarization of the muscle end plate and has features of the classical depolarization blockade. Classical depolarization blockade, what we have discussed, is also known as the phase 1 blockade. Okay. This depolarization declines shortly afterwards and repolarization occurs gradually despite continuous presence of the drug at the receptor. Usually after some time the actions of the muscle and the nerve fiber gets back. Okay. But neuromuscular transmission is not restored and phase 2 block supervenes if it is given in very high doses and in some of the muscle fibers where and in some of the cases where the succinylcholine, for example, is not metabolized well. So, there are some genetic variation in the succinylcholine metabolism. For example, in some person there may be some atypical cholinesterase deficiency. Succinylcholine is metabolized by butyryl cholinesterase or atypical cholinesterase. So, in many people, it is very common in the Mediterranean people that this butyryl cholinesterase is not present or present less. So, in those patients, when we are giving this succinylcholine, they will be metabolized less. So, the amount of the succinylcholine that is present in the neuromuscular junction will be for a long duration of the time, more amount is there. So, in those cases, after this phase 1 block, which is a classic depolarization block, there may ensue some phase 2 block, and phase 2 block is like that of the non-depolarizing or competitive block. Okay. So, phase 2 block is slow in onset, results from desensitization of the receptors to the acetylcholine. So, the receptors become desensitized to the acetylcholine because for a long period of time the succinylcholine molecule is there. So, the muscle membrane is nearly repolarized, recovery is slow, contraction is not sustained during tetanic stimulation. Tetanic stimulation means some burst of the electrical activity is given so that there will be some rapid movement of the muscles. This tetanic stimulation is used in to see whether the anesthetic practice is okay or not. So the block is partially reversed by the anticholinesterases in man, and fast contracting muscles like tibialis anterior cat, normally only phase 1 block is seen. So normally we are seeing with the succinylcholine or depolarizing blocker the classical depolarizing blockade. This is also known as the phase 1 blockade. But in some of the muscles or in some of the people where the succinylcholine is not metabolized well, or if this succinylcholine is given in very large volume, in those cases after phase 1, phase 2 block can also happen. Phase 2 block is like that of the competitive blockade. So phase 2 block may be seen in man when succinylcholine is injected in high dose or infused continuously, particularly if fluorinated anesthetics have been used. So when you read about the anesthetics, there are some fluorinated anesthetics like halothane. There may be some interactions and there will be less metabolism of these drugs. Succinylcholine readily produces phase 2 block in patients with atypical or deficient pseudocholinesterases. Already I have discussed. So here in these cases phase 2 block usually ensues. So this is problematic. If the patient goes to the phase 2 block, it is difficult to reverse back to the normal position. So this is the phase 1. Usually the succinylcholine attaches leptocurare, long and slender molecules. They causes sustained persistent depolarization. But if there is some deficiency of the atypical cholinesterase, if it is given in large volume, then the phase 2 block happens, where the succinylcholine you can see it is directly attaches with the sodium channels. There will be desensitization of the receptors to the acetylcholine, and ultimately it will be difficult to reverse back. So succinylcholine, about this is the most commonly used muscle relaxant for passing the tracheal tube. So endotracheal tube insertion, usually succinylcholine or within the competitive Vecuronium can be used. It induces rapid, complete and predictable paralysis with a spontaneous recovery in approximately 5 minutes. So excellent intubating conditions like relaxed jaw, vocal cords apart, immobile with no diaphragmatic movements obtained within 1 to 1.5 minutes. So in those cases, for example, the patient comes with road traffic accident, patient is shock, immediately we have to intubate the patients. We are giving the succinylcholine injection. Within just 1 to 1.5 minutes, there will be relaxation of the jaw. The trachea will be open, we can insert the endotracheal tube and then attaches the ventilation. So this is needed because it will be life saving. So if the duration will be more, the patient will die. That's why this duration is important. So it should be avoided in younger children unless absolutely necessary, because there is some risk of hyperkalemia and cardiac arrhythmia is higher. The main problem of this succinylcholine is hyperkalemia. Potassium level is increased, and you know when the potassium level is increased, hyperkalemia always leads to cardiac arrhythmia. Okay, so that's the problem. So there may be some risks of regurgitation and aspiration of the gastric contents. This is increased in case of the gastroesophageal reflux disease patient. So in some patients when there is reflux, so the gastric content usually comes out through the esophagus. So there is always chances of the regurgitation and then aspiration within the lungs, because the muscles will be relaxed. So there will be always the problem of the aspiration of the gastric content. So small rapidly moving muscles like eye, jaw, larynx are relaxed before those of the limbs and trunks. This is needed. Ultimately intercostals and finally diaphragmatic paralysis occurs, that may lead to respiratory paralysis also. Recovery happens in the reverse order. Already we have seen this is similar to that of the competitive blockers. Muscle relaxation onset within 1 minute, peak within 2 minutes, duration is 5 minutes. Just very short duration. Longer duration relaxation needed, usually continued IV infusion, but again there is always chances of the phase 2 block. That is the problem. So mainly it is used in different types of the brief procedures like endotracheal intubation, most common. Apart from this, it can also be used in laryngoscopy, bronchoscopy, esophagoscopy, reduction of the fractures. If there is fractures, we have to reduce, reduction of the fractures is done under the succinylcholine coverage, dislocations, and to treat the laryngospasm. So this is the use. Rapid endotracheal intubation during induction of the anesthesia. Occasionally succinylcholine is used by continuous IV infusion to produce controlled muscle relaxation of longer duration, but already there is some flip side. During electroconvulsive therapy to prevent injury, in some cases used, but mainly the most common use is the first stanza. So different types of the scopies endotracheal intubation and different scope is usually the succinylcholine is used because its duration is very favorable. You can see muscle relaxation happens and its action also ends within the 5 minutes. Adverse effect is transient increase in the intraocular tension. So there may be some glaucoma like changes may be there, but the most problem is the hyperkalemia. Already I have told. Fasciculation happens because succinylcholine causes a depolarizing blockade. So initially there will be some rapid muscle contraction, fasciculation. When there is some rapid muscle contraction, there will be release of the potassium from the cells. That is why there will be chances of the hyperkalemia. And again, due to these fasciculations, there will be muscle soreness or muscle pain later. That is also an adverse effect. Succinylcholine apnea can happen if there is some butyrylcholinesterase deficiency. Malignant hyperthermia may happen when used along with halothane in general anesthesia. Severe rise of the body temperature, seizures, convulsion all can happen in some of the cases. Usually the treatment is done by rapid cooling of the patient and the dantrolene is given. Dantrolene is a centrally acting muscle relaxant. Muscle pain already I have said, muscle soreness. So what are the adverse effects of the succinylcholine? The principal adverse effect is the hyperkalemia. Why hyperkalemia happens? Because succinylcholine is a depolarizing blocker. When the depolarizing happens, there will be some muscle twitching and fasciculations initially. When there is fasciculation means rapid muscle contraction, there will be release of the potassium. When this hyperkalemia happens, there is always chances of the cardiac arrhythmia, and this hyperkalemia, this muscle twitching also leads to muscle soreness, and all this leads to malignant hyperthermia, succinylcholine apnea. Already this can happen. So this is how the twitching response happens in competitive and depolarizing blockers. So this is known as the, you can see this is the d-Tubocurarine is given. When the d-Tubocurarine is given, you can see this is the normal muscle response when a electrical stimulus is given. D-Tubocurarine is given, there is gradual decrease of the twitching response, gradual decrease of the contraction. So this is known as the fading. Already we have said fading of the muscle contraction, d-Tubocurarine is given. When the tetanic stimulation is given, tetanic stimulation means rapid brief burst of the electrical stimulus is given. So after that there will be some post-tetanic potentiation, there will be somewhat rise of the muscle contraction, and again there will be decrease of the muscle contraction since the d-Tubocurarine, that is the competitive neuromuscular blocker, this is the prototype one, is already present. Now we have to reverse. So we can give neostigmine. When the neostigmine is given, you can see there will be again increase of the muscle relaxation and gradually back to the normal. So ultimately it reverses when the neostigmine is given. This is for the competitive neuromuscular blocker. But when the depolarizing blocker like the succinylcholine is given, you can see this is the normal one. Here the succinylcholine is given. So when the succinylcholine is given, brief there will be rise because this is the depolarizing blocker and there will be fasciculation and twitching when the succinylcholine is given. So immediately after giving the succinylcholine, there will be increase of the muscle contraction. This is due to the fasciculation, that also leads to hyperkalemia. And then there will be again gradual decrease of the muscle contraction like that of the competitive blocker. And if again we are giving that this tetanic tetanic stimulation, there will be again rise of the this muscle action potential, but this rise is less than that of the competitive blocker. And again you can see when the neostigmine is given, there will be no reversal because neostigmine reverses only the competitive neuromuscular blocker, not the depolarizing blocker. So again it continues to be decreased, the muscle contraction. So you can see, so this is causes, so this is the fading. So it is clear. So the first panel is about the competitive neuromuscular blocker, where there is be when the competitive neuromuscular blocker is given, there will be gradual decrease of the muscle contraction. This is known as the fading. When tetanic stimulation is given, there is some post-tetanic potentiation and again it decreases, but it can be reversed by the neostigmine, which is an anticholinesterase agent. But in case of the depolarizing blocker, when the depolarizing blocker like succinylcholine is given, since they are depolarizing, there will be brief fasciculation and twitching of the muscle, so that there will be increase. and then it gradually decreases and paralysis happens. Again, due to the potential, when the tetanic stimulation is given, there will be somewhat rise of the muscle contraction, but this rise is very less and it will not be reversed by the neostigmine. So it is clear about these two. So again the difference, so competitive ones causes competitive blockade, these are non-depolarizing, usually it is causes single block. The depolarizing blocker causes persistent depolarizing agent, it may cause dual block, phase 1 and phase 2. This can be reversed by the anticholinesterase agent, this cannot be reversed by the anticholinesterase agent. Initial fasciculations are not present in the competitive blocker. Depolarizing blocker, they may be present. Slow onset, long duration, usually the Succinylcholine, rapid onset, short duration. It may release histamine, it does not release histamine. So it is clear about, there are so many difference between the competitive blocker and the depolarizing blocker. Okay. So the clinical monitoring of the neuromuscular block. So in anesthetic practice, neuromuscular block is monitored by recording the contractile response of the thumb muscle usually. Already you have seen the extraocular muscles or thumb muscles are affected first. So there are some protocols. So we are giving some impulse and seeing whether the contraction of the muscle is back or not. So after operation we are giving some impulse to see whether the muscle contraction is back or not. Accordingly we can say the actions of this muscle relaxant action is ultimately finishes, or it ultimately is not finishing, the muscle relaxant action is not finishing. So the anesthetist has to give some antidote like this. So this protocol, one of the protocol is the train of 4 protocol, train of 4, that is 4 subsequent impulses given. So 4 supramaximal electrical stimuli are applied at 2 seconds. So ultimately it is a 2 Hz impulse, and contractions of the thumb muscle contraction is noted. Train of 4 ratio is obtained by dividing the strength of the 4th contraction and that of the first. So when there is some untreated person, that when we are giving some this impulse, all 4 will be the same. Okay. So you can see when there is no drugs, we are giving 4 impulse. For example, in mind there are some electrical stimulus is given, there will be contraction. The 4 contractions will be similar. So this is in the no drug normal person. The train of this train of 4 ratio will be 1. So when some competitive block is given like Pancuronium, you can see there already we have seen there will be fading. So there will be gradual decrease of this muscle action potential. So there will be gradual decrease. So train of 4 ratio ultimately decreases, like it will be 0.5 or like this. You can see gradual decreases. But when the Succinylcholine depolarizing blocker is given, there will be decrease of the normal contraction. So this is the normal contraction so high and it will be small, but there will be no fading or less fading, that is these 4 stimuli are more or less similar. Okay. So there will be less contraction, but these are more or less similar. So train of 4 ratio is more or less 1. There are some other protocols like double burst stimulation protocol, etc. Details is not required. So this is about the train of 4. So all these are usually helps us to see whether the patient is back to normal or not, and also for you it is clearer to understand the difference between the competitive blocker and the depolarizing blocker. What is the fading and why in the depolarizing blocker there is no fading. Okay. Train of 4 protocol. So the same thing as a difference. So Succinylcholine generally requires no monitoring. So since there is the train of 4 ratio is 1 and it is shorter duration, usually monitoring is not needed, but competitive blocker apart from the Vecuronium or Vecuronium, the most of the others are the longer acting, so we need monitoring. So we have to give the nerve impulse and to see whether the train of 4 ratio is increasing or not, or decreasing like this. So according to the fading. So this is another, just remember the name, double burst stimulation protocol, another protocol where less impulse is given, because there are 4 electrical impulses given, so this is painful. So double burst is usually less painful. It is also used in different anesthetic practice. So train of 4, so fading in train of 4 is seen in case of the competitive blocker. Fading is not seen in case of the depolarizing blocker. The contraction will be uniformly less like that of the normal in case of the depolarizing blocker. Okay, like this. So there are some drug interactions like neostigmine reverses the action of the competitive blocker or non-depolarizing blocker. but they do not reverse the depolarizing blocker. His halothane aminoglycoside antibiotics like gentamicin, we will read later, they have some ganglionic blocking properties. So, there may be some interactions and there may be toxicity with these neuromuscular blocking agents. Halothane also can cause malignant hyperthermia if it is used with succinylcholine. So, this is about the peripherally acting muscle relaxant. This is the prime principal part of the skeletal muscle relaxant. Apart from this, there are some directly acting muscle relaxants like Dantrolene. So, Dantrolene mainly acts on the ryanodine receptors. Ryanodine receptors is basically a calcium channels which is present in the sarcoplasmic reticulum of the skeletal muscles and prevents calcium induced calcium release through this channel. So, you know, in the sarcoplasmic reticulum again the muscle action potential comes, calcium enters within this and that also leads to more calcium release. So, when the calcium release happens, there will be action potential generation like this in the physiology. So, calcium induced calcium release, this will be diminished when this dantrolene is given. So, intracellular release of the calcium is needed for this excitation contraction coupling and this is interfered with. Fast contracting twitch muscles are affected more than the slow contracting anti-gravity muscles and basically this dantrolene is the drug of choice for malignant hyperthermia. So, if you are asked what is the drug of choice for malignant hyperthermia, it is the dantrolene or dantrolene sodium. What is dantrolene? Dantrolene is a directly acting muscle relaxant. Why directly acting? Because it acts on the ryanodine receptor which is a calcium channel receptor present in the sarcoplasmic reticulum. That mainly helps in the calcium induced calcium release from the sarcoplasmic reticulum that causes excitation contraction coupling and muscle contraction. Okay. Muscular weakness is the dose limiting side effect. Troublesome diarrhea may happen with this dantrolene. Long term causes dose dependent serious liver toxicity also can happen with the dantrolene. Next, coming to the ganglionic blockers. Ganglionic blockers again may be competitive blockers and persistent depolarizing blockers like nicotine in large doses. Usually there will be no clinical use of the nicotine in large doses. Some nicotine patch etc. are usually used for the smoking cessation and competitive blocker in very less it can be used like hexametonium, trimetaphan, mekylamine. These are the ganglionic blockers, competitive ganglionic blockers. Okay. So, ganglionic blockers, how it helps? Again, some ganglionic blockers, there may be some parasympathetic or sympathetic in different systems. Some parasympathetic system takes upper hand, in some system sympathetic system takes upper hand. So, when we are using ganglionic blocker in those organ which is the predominant one, that will be inhibited. So, accordingly the action will happen and these are the pure ganglionic blocker, these three. Okay. Apart from this pure ganglionic blocker, there will be also we have discussed the succinylcholine or different types of the neuromuscular blockers. They also have ganglionic blocking property. There are some other drugs, for example, the antibiotic, you will read about this, aminoglycoside, they have ganglionic blocking property. So, this ganglionic, autonomic ganglionic blocking property, these drugs when you are using, we have to keep cautious about this because we are using for one purpose, but in some other organs they can block the ganglion and ultimately there will be problems. Okay. So, apart from this directly acting muscle relaxant, there will be some centrally acting muscle relaxants lastly. Centrally acting muscle relaxants are mainly used in different spasmodic conditions. Details is not required, there are some names already we have discussed like baclofen, diazepam, you will read about the diazepam in the sedative hypnotic chapter. There will be tizanidine and there will be thiocolchicoside. So, baclofen, tizanidine, thiocolchicoside, these are the centrally acting muscle relaxant. Mainly these are used in different types of the spasmodic conditions. The most common spasmodic condition is the wry neck or torticollis in the neck, wry neck or torticollis we can use. There are different types of the cerebral palsies. There are, you may be heard about the amyotrophic lateral sclerosis. Stephen Hawking has amyotrophic lateral sclerosis. These are different types of spasmodic conditions. To diminish these spasms, we can use these centrally acting muscle relaxant agents like baclofen, tizanidine, thiocolchicoside. So, all this is about the all this is about the skeletal muscle relaxants. So, within the skeletal muscle relaxants, again I am giving a summary. The most important is the neuromuscular blocking agents. Neuromuscular blocking agents, there will be two types, competitive type or non-depolarizing type, another is the depolarizing type or non-competitive type. Competitive type example is the Pancuronium, Vecuronium, etc. The prototype is the d-Tubocurarine, which competes with the acetylcholine, while ultimately the depolarizing blocker, the main example is the Succinylcholine, which attaches with the NM receptor, but they have submaximal intrinsic activity, that's why they causes persistent depolarization. Now this Succinylcholine is metabolized by the atypical or butyrylcholine esterase. So if some patients have butyrylcholine esterase deficiency, or if this Succinylcholine is given in very large amount, so ultimately there will be phase 1 and phase 2 block. Phase 1 block is the normal depolarizing blockade, but if this problem arises, there will be phase 2 block. This phase 2 block is like that of the competitive neuromuscular blockade, where there is desensitivity of the NM receptor towards the acetylcholine. So if the phase 2 block ultimately happens, there will be problems of the reversal. Competitive neuromuscular blockers can be reversed by the neostigmine, remember, but non-competitive or depolarizing blockers will not be reversed by the neostigmine. Again, this is very important. Again, how we can determine that the patient is coming out of this muscle relaxation or not. This can be done by giving different types of the electrical stimulus. There are different types of the protocols like train of 4 phenomenon. Train of 4 phenomenon means we are giving 4 stimuli and we are just doing the first stimuli, the ratio of the first stimuli to the 4th stimuli. Usually the competitive neuromuscular blocker causes the fading phenomenon, gradual diminish of the muscle contraction. But in case of the depolarizing blocker, when it is given, since there is depolarization, there will be subsequent muscle fasciculation and twitching immediately after giving Succinylcholine, that causes somewhat rise of the contraction, and then there will be decrease of the contraction. But in general, the train of 4, the ratio will be 1 because the contraction is similar in all of the contraction level, but it is somewhat very less in comparison to the normal muscle contraction. So and the main adverse effects of the Succinylcholine is the hyperkalemia. And hyperkalemia is aggravated when it is given with some other drugs that also causes hyperkalemia. And hyperkalemia can give rise to the cardiac arrhythmia. There may be some malignant hyperthermia. And this malignant hyperthermia can be treated by another drug which is a directly acting muscle relaxant, which is the Dantrolene. Dantrolene mainly acts on the ryanodine receptor, which mainly is a calcium channel. Dantrolene can be used in the malignant hyperthermia. Apart from Dantrolene, there are some centrally acting muscle relaxant like thiocalcicoside, tizanidine, baclofen, etc. They are mainly used in different types of the spasmodic conditions. For example, spasmodic torticollis or Rhineck, cerebral palsy, amyotrophic lateral sclerosis, etc. So this is all about the skeletal muscle relaxant.